you know, the history of attention to pandas actually goes to late 80s, early 90s. There was a rumor all over the NIH that there was a connection between the Streptococcus group A and obsessive compulsive disorder, but it was just a rumor. Finally, somewhere between 92 and 96, Dr. Svido and a couple other guys like Albert Allen started to pay attention to it, and finally, in 1998, they published that seminal work on direct connection between the streptococcal infection and the obsessive compulsive disorder. Well, as you were already told, the result was just a mess. Every interested party went berserk. Specialists in movement disorders went off the cliff. Okay, strep guys went off the cliff. Okay, psychiatrists went off the cliff. So it was massive suicide, and the problem was that actually the research by 2000 stalled. The last NIH research was conducted sometimes in 1999, 2000. In some, really strange way, I got involved with that in 1999, and a friend of mine, Beth Latimer, who is neurologist in Bethesda, we independently got involved with it. She got in 2001. And so from 2000 until about 2010, NIH was not doing any research, and all the research done was actually done by two of us. So by 2010, I had about 250 cases that I could report, and Beth, who was working with plasmapheresis, had about 70 cases. So in 2010, it was reported, and at that time, the grants for research on pandas were reinstituted, and it's going full steam since. My idea of today's speech is pretty simple. Everybody is talking about pandas, OCD, tics, kid is doing this, kid is doing that. But when you are in a practice and you got a 15 to 30 minutes to diagnose the kid, there has got to be some kind of system that you can get the diagnosis and decide where you go from there. What do I do now? Okay. Yeah, well, that's what I'm trying to do, but it's not. Okay. All right. All right. So let me explain symptoms, their incidence, and how we use them in diagnosis. Obsessive behavioral symptoms, we have two groups of symptoms: behavioral symptoms, somatic symptoms. Trust me, it's not a perfect division, but the best I can do. Obsessive compulsive symptoms, intrusive thoughts, running thoughts, general anxiety, phobias, compulsions, etc., they are actually present in every single case of pandas. If you have a child who doesn't have OCD symptoms, pandas is extremely unlikely. So we start with the obsessive compulsive symptoms, general anxiety, and the separation anxiety. Now, those are two totally different symptoms. General anxiety is uptight kid who is afraid, phobic, or whatever. Separation anxiety, it's classic of pandas. It's present in almost every case, and it is the child who, out of the blue, does not leave the mother's shadow. Mother goes to the bathroom, kid is, throwing himself on the floor in front of the bedroom door and yelling until mother comes out. Mother goes to the store, she cannot leave the kid at home, he has to go with her, etc. The next important symptom is behavioral regression. Now, this is something that's frequently ignored, but it's quite obvious. You have a 17-year-old girl who is sitting in father's lap and sucking her thumb I think you got a problem, okay? So these children routinely, again, in most of the instances, in just about all patients, they can have a baby talk, other behaviors unbecoming of chronological age. You see the child who is 4, 5, 10 years younger behavior than it should be. The next one is sleep disorders. That has been identified in about 84%. You have a long bedtime rituals, insomnia, night terrors, frequent waking up, going to the parents' bedroom, refusal to sleep alone, okay? Now, the suddenness of onset of insomnia is something you have to keep in mind. Then we have a hyperactivity and inattentiveness that's identified in about 71% of all patients. Now, the reason I'm so careful in giving you all the percentages, and I will give you certain formulas later on, is American Academy of Pediatrics will assign the code to PANDAS sometimes this year, and it's going to become a valid diagnosis. The danger is that every misbehaved ADHD kid, suddenly mothers are going to suspect the PANDAS, okay? So, we have to be very careful in getting to diagnosis. Aggressiveness, that has been identified in about 62% of the patients. When I'm speaking about that, if you have a 4-year-old kid who is just throws the temper tantrum, is trying to kill the brother or sister, or it looks completely out of his skull, that's what I'm really describing. Now, Now we go to somatic symptoms. Now, Beth Latimer did some research, and she basically identified general hypotonia in most of the patients. There is a deterioration in fine motor skills and handwriting in about 89%. So the kid was great in throwing the baseball. He's not doing so well now. After that, we have a urinary frequency, enuresis, daytime accidents, inability to concentrate, tics and adventitious movements, persistent non-specific abdominal complaints. Now, this is something that we still haven't figured out. 79% of these patients have a real and significant abdominal pains. They are not related to any particular event. They are not related to any infection or abnormality, because we've had about 120 kids that were scoped and findings were negative. Finally, it's a short-term memory impairment. This is something that is reported continuously. Kid, you ask him to take a garbage out, you have to repeat it 5 times, and kid is looking at the parent like, you never told me so. Further is, obviously, if you don't have a short memory, you're not going to learn much, especially not math. There is this emotional lability and depression where the kids start crying for no reason at all. This is the fascinating one, and I'm going to just spend a few minutes extra. Now, here sounds, light, touch. However, if you look at very carefully the past medical history in these kids, you're going to find that somewhere between 3 and 4, a lot of these kids couldn't take a certain labels, you would have to cut the labels out, or preferred always the same pajama. So there were some sensory issues. Uniformly, these kids come with sensory integration disorder, but I believe it's a little bit made up diagnosis, and it's probably in some way precursor of what we see in PANDAS. Now, eating disorder, in my population, incidence is 17%. Now, Sue Svido and Beth Latimer feel that it's higher, probably somewhere between 40 and 50%, and the difference is in interpretation. For me, in my population, anorexia was not only refusal or pickiness about food, but actual weight loss of 10% or more. In their population, they didn't account for the weight. So this is where the difference is. Now, OCD is not going to kill you. It's not going to kill the kid. Tics are not going to kill the kid. However, anorexia will. So I think this is the only true emergency that we have in PANDAS and should be always kept in mind. Now let me give you a couple of examples that are totally off the wall. 3.5 years old kid walks into, comes to my office. He stopped eating 2 weeks before the visit for no reason at all. The only explanation, I will eat tomorrow. Goes to one of the centers here, gets the central line inserted. It's fed intravenously and basically does not improve. Comes to my office, we test him with just a simple steroid burst, he's eating 24 hours later. So, the difference in anorexia, and I will explain it in a few moments, is that typical anorexia that we see in adolescents and young adults has a completely different presentation than the anorexia we have in PANDAS. Now, selective mutism is something that scares bejesus out of the parents. Kid wakes up in the morning and it's mute, does not speak. We see that in about 7%. Hallucination, one other, scary thing for parents, where the kids, the kid goes to school and is doing this. And the teacher is asking him what happened. Oh, I'm just getting Martians off my shoulder, okay? So hallucinations, both visual and auditory, do happen in about 9 to 10% of the cases. Finally, and this is the one that disturbs most of us, doctors, is the intermittent dystonia. The kid comes into the office and suddenly passes out. And then wakes up, he or she is fine, 5 minutes later passes out again. What is fascinating is that if they pass out, they never fall. They kind of slide, okay? And it's almost faked seizure. So this is something, you should notice and not necessarily panic about. Now, in trying to make some kind of a reasonable formula, how do you quickly approach the diagnosis of PANDAS? Myself and now Sue, we are putting it together, is we divided all these symptoms into 3 different criteria. There is absolute criteria. That means that should be present in just about every case, and that is a sudden onset. And as Dr. Manabi said, this is classic. Kid goes to bed on Thursday evening perfectly fine, wakes up as a Martian on Friday morning. So sudden change, usually within few hours or a day or two, it's what is present in almost every case. So without that, things get a little bit complicated. You have that, the rest of the diagnosis is much simpler. Major criteria, that's a presence of OCD, because we have seen it present in every case. Separation anxiety, again, according to statistics present in every case, and anorexia. Those are three symptoms that we consider major criteria. Okay, now, here is the explanation on the separation anxiety. There are two types of separation anxiety. There is a type 1, let's call it, that is continuous daytime, nighttime physical dependency on parents. But that is usually seen in children 10 years or younger. In children older than 10 years, there is a different type of separation anxiety, and it is actually related to a physical place that they live. So they are fixed on a certain room, on a home, they don't want to leave the home, etc. So this is important to remember. Both of these are the separation anxiety and should be accounted as a symptom. Now, there are subtypes of anorexia nervosa. There is a subtype 1, and that one is classic for PANDAS. Kids stop eating, they lose weight. Result is the same, but the cause is different. You're going to find out a lot of them have a fear of choking on food, so they cannot swallow. They have a fear of vomiting upon ingestion of food, so they don't want to swallow. They cannot swallow because they have intolerable smell or texture, or to give you another example, because food is poisoned. So actually, all three of these are OCD, obsessive compulsive component of the symptom, not a typical anorexia. What is complicating the whole thing is that we see that usually in 10 years and younger. However, if the situation is not treated and persists beyond 10 or 12 years of age, then they slowly over a period of time revert that into body imaging problem. Now, so we had the major criteria, three of them, and now we have a minor criteria. They are divided in groups. One group is sleep disorders, behavioral regression, emotional ability, hyperactivity, aggressiveness, learning disability, and hallucinations. Group 2 is hyper-alert appearance, hypotonia. Now, when I'm speaking about hyper-alert appearance, this is something that we have found, and I think I want to define it for you. So kid walks into your office, and she, sits straight, or he sits straight, okay, and he's just watching, does not move, expecting the worst. Now, a lot of kids, when they come to your office, expect the worst, but after a few minutes, they do relax. However, these kids, throughout the visit, if it's 1 hour, it doesn't matter. They stay ready to fight. So minor criteria is hyper-alert appearance, hypotonia, mydriasis. Now, this is something that actually I described in 2006, and I noticed in the acute stages of illness, these kids' pupils are just huge. And as the episode wanes down over a period of time, the pupils get smaller. Urinary frequency and enuresis, daytime incontinence, short-term memory loss, increased sensory responses, fine motor skills deterioration, dysgraphia, and tics or adventitious movements. So formula, it's actually pretty simple. If you have a patient that had a sudden onset of symptoms, essentially what you need, you meet the absolute criteria, you need two major criteria. So, if you have a 2 out of these 3 symptoms, plus the sudden onset, diagnosis, it's extremely likely. I will give you percentages in a second. Now, the problem is that if the child started with the symptoms, at 2 or 3 years of age. What does happen? Actually happens more frequently than we knew. How do you define obsessive-compulsive symptom in a 3-year-old child? You can't. They have their temper tantrums. They can have some strange behaviors, but most of the 3-year-old behave strangely, okay? So if you are evaluating patients number of years later, parents might not provide you with a sudden onset, although probably there was one. Well, you have to work with it. And so the formula 2 basically addresses that problem, where we have a no sudden onset, and what we like to see is a 2 major criteria, and then we like to see plus 3 minor criteria, and out of those 3, you have 2 groups. One group is here, so it has to be at least one of the symptoms from each subgroup, okay? Now, statistically, here is how it works. So far, we have calculated that probability is 90% if you follow this, that the diagnosis of PANDAS is likely. So I think you are already doing pretty well. Now, how do we improve the odds? Okay. What is the workup? Now, you can spend $50,000 on the kid, okay? So, you know, I think it's important to find what testing is going to help you out in further the diagnosis. So here is basically what I do, and I think this probably all of us agree on that. Positive group A streptococcal titers. Now, let me reflect on it for a few minutes. There are actually 3 titers that we use. There is ASO titer, that is probably older than me, oh, much older. There is anti-DNSB that is just about as old as I am, and then there is a streptozyme titer that was introduced about 42 years ago. So, one of the problems is obvious. We got a 21st century disease, and we are evaluating it with 19th century tools. So, you're going to have a problem. Second important thing that is always forgotten is that you don't have just a single strain of group A streptococcus. Actually, there are 120 different strains. So the question that comes out, as we knew in the past, that certain strains were more likely to occur with rheumatic fever, the question that is raised, and we don't have an answer, are there, let's call them pandasogenic strains that are facilitating development of PANDAS. The reason we are seriously looking at that there were at least 5 or 6 clusters of PANDAS. They were in Silicon Valley, they were in San Francisco, there was one in New Jersey, where at the same time, in the same facility, like in New Jersey, you had 7 cases of PANDAS. So I think this is something we have to look. Now, here is where we have a real problem. So let's say you do all 3 titers, and they're negative. Well, does that exclude PANDAS? No. Now, you have all 3 titers and they're positive. Does that confirm the PANDAS? No. You know, you can break your leg and have a strep throat. It doesn't mean strep throat has caused you a broken leg. So I think the important thing is that presence of strep, it's a supporting evidence, but presence of strep does not confirm the diagnosis. Just to give you the problems that we have been facing, Pat Cleary at University of Minnesota did ASO titers on 10 kids with a clinical and a diagnosis, including the throat culture of strep. And he did the SO titer on them and found that actually there was no immune response to strep in 4 out of 10. Then he did so-called ELISA SO titer, what is experimental test, and found they were positive. So actually, our testing for strep is not terribly good. Second important thing is, okay, the theory that started in 1998 is that because of the mimicry and misreading of epitopes on the strep body, okay, you have this, we call it misguided immune response. The only other common microorganism that uses mimicry as a defense mechanism is Epstein-Barr virus. So we have documented, especially in kids with anorexia, elevated Epstein-Barr virus titers, both IgG and IgM, and we believe that that could be the second microorganism. Now, if you look at the literature, you're gonna find Mycoplasma pneumonia, Lyme disease. The only thing is missing is leprosy. Well, actually, none of these microorganisms, at least as we understand it today, can cause PANDAS. To start PANDAS mechanism or reaction, you do need Streptococcus group A and or possibly Epstein-Barr virus. Every other microorganism, if the mechanism of PANDAS is in place, it's can and it does cause the recurrence of symptoms. So the cases described with Mycoplasma pneumonia or cases described with the Klebsiella and Staphylococcus aureus, MRSA, there were a number of cases, actually were the second or consequent episode, not the initial one. Now, am I boring you or can I go through this, okay? All right. All right. The next thing I check for is IgE level. Now, IgE level can be because you're allergic on your grandmother or because you have PANDAS. So it's non-specific autoimmune indicator or marker. However, we have found that to be elevated in about 45 to 50% with the PANDAS. Leukopenia. Now, this is something that we have been kind of wrestling with because a lot of these kids have had the recurrent infections. Recurrent infections can cause in a long-term leukopenia. So is that part of the PANDAS or just a result of it? We don't know, but we have noticed it. Sleep studies, abnormalities have been done at NIH. Obviously, I'm not suggesting that to be done, but I'm just telling you what has been done. There were initially in 1998, there was a group of patients that had their MRIs done, and they described in those MRIs swollen basal ganglia. It was kind of awkward description, and we have looked into it after that. And I personally haven't been able to find any difference. So this is something that you might use, but it's too expensive. And to be honest with you, payoff is miserable. So it's just not worth it. Finally, I'm sure you're going to hear about the PET scan. Now, PET scan, Dr. Chugani, who was in Detroit and then moved to Delaware, he did some work with it and found activation of microglia in patients with PANDAS. Again, it's a $2,000 to $3,000 test, and when everything is said and done, I don't think you really get much smarter with it. So I think as experiment is nice, but as a routine, no, I would not recommend it. Finally, as you can see, I ignored two of things, and that's important. EEG abnormalities. This is something that has been described by NIH, and they're, what they said, non-specific. There are spikes, but they're not epileptogenic spikes, okay? So they're actually now working, trying to classify it and kind of give us that as a tool. But it's in development. Finally, I want to just, okay, this is the cute one, okay? It's circulating immune complexes. As you know, circulating immune complex is a result of antibody and antigen embracing itself and killing each other, okay? So you have two dead carcasses that have to go somewhere. We assumed that they are being normally excreted through the kidney until about 4 or 5 years ago, we had a couple of cases that were refractory to intravenous immunoglobulins, and in them we did circulating immune complexes and found them to be all elevated. Then we went back to the literature and found actual description of deposition of circulating immune complexes in the blood vessels of basal ganglia as a result of completely different condition. But they did alter the blood-brain barrier, so that's a possibility in severe cases that might exist. The reason I'm mentioning that, and reason you might do that, is not to confirm your diagnosis, but actually the children who have elevated circulating immune complexes don't respond to intravenous immunoglobulin positively. So actually you might have to address that first with the steroids or whatever, and then you treat them. Now, when we are making diagnosis, so this is your workup, okay? The next step is, if the child fulfills the criteria, you put them on antibiotic. 2 weeks, that's my personal preference, of beta-lactam antibiotics, unless they're obviously allergic to it. Now, it is expected in children 12 or younger that you're going to have a positive response in about 70-75% kids. And in children older than 12 or 13, it goes down to about 50%. Improvements are frequently very significant. However, there is a little puzzle there. So you have a child who has a negative streptococcal titers. You have a child who has a negative throat cultures. But you still give him antibiotic and you still expect positive response. What's the point? Well, the point is that there is a side effect that beta-lactam antibiotics have that actually was reported in 2005, and we applied that to PANDAS in 2010. And that is, they just offer accidental neuroprotection. They actually increase the resistance of the blood-brain barrier. So, if the child that you are diagnosing has a positive, significant objective response to beta-lactam antibiotics, that probably makes diagnosis about 95% certain. Now, literature is going to give you a few wrinkles, so I want to clear them up. Now, Tanya Murphy has reported a series of cases treated with cephalosporins or with augmentin, then somebody else did azithromycin, where they reported significant improvements, almost complete cure, by 1 year after giving the antibiotics. So, when you read it, it sounds you cured it, let's have a beer, forget the whole thing. Well, unfortunately, that doesn't work that way. I have followed kids now for 18 years, and unfortunate thing is that most of them, if not all of them, after a remission that they experience with antibiotics, eventually do develop symptoms again. Let me give you an example. 8.5-year-old kid goes to see grandma in Bulgaria, comes back, and at noon starts crying that he will not be able to fall asleep. That was his obsession, okay? His GSA titers were positive, treated for 2 weeks with augmentin, and actually, that was a number of years ago. I decided that was my only chance to see the kid first time, because most of the kids I saw until that time were, had the symptoms for years. And I decided to give him one other 2 weeks, and lo and behold, kid was fine. Everything was fine. I followed him in the office just as a pediatrician. 6 years later, mother calls me that he had developed severe tics. I mean, the tics that were almost dislocating his neck. We re-examined him, negative GS titers, but guess what? He had a positive MRSA. Treated it, minimal improvement. And so we treated with IVIG, and that was resolved. So, I want to caution you, when you are talking to the parents, please tell them, yes, antibiotics have a very good chance to put the kid into remission. That could last weeks, months, or sometimes few years. But you gotta tell them that there is a very good chance that the symptoms could come back. Now, okay, one of the things that I was always concerned about is, okay, so I have a kid who does not respond to antibiotics. So I'm actually stuck with the medical history, questionable blood work. What else can I do to prove the point? And so in 2004, I believe, I kind of tried to use simple steroid burst, 1 milligram per kilogram of prednisone for 5 days. And lo and behold, those 25%, because if you remember I said about 75% respond to antibiotic, 25% don't. And then as older they get, the number of responses to antibiotic goes down. I found that the other group, unresponsive group, actually had a very, very nice positive result with the steroid burst. So I used that as additional diagnostic tool, and since really it has no side effects, it's cheap, I think it's worth a shot. Before I get further, okay, all right. This is something that is relatively new. Treating children with PANDAS essentially is a relatively simple process. You try antibiotics, child has a recurrence, you go with intravenous immunoglobulin. Okay? Side effects minimal. But the problem we experienced for years was the recurrence rate. Recurrence rate in my group until 2009 was about 18%. So they need one other treatment. So, yeah, we did as much work as we could to figure out, and we all concentrated at adenoids and tonsils, assuming there is a chronic infection, vacuolization, inappropriate, reach by antibiotics, etc. And so we started to discuss with ENT specialists. And there are several, there is at least a couple very good ones here in the western suburbs. And so we started to remove them, and we did see the decrease in incidence of recurrence. But believe it or not, I was completely wrong. Had nothing to do with the chronic infection. It appears to be, and that was reported by Pat Cleary again, and Aguilar from Colombia just about 6-7 months ago, that GAS, group A streptococcus, by infecting the adenoids and tonsils, induces the production of killer cells, Th17 cells. Those cells migrate along the olfactorial nerve straight into the brain, discharge the cytokine. Cytokine opens the blood-brain barrier, and Merry Christmas, you got a problem. Okay? So actually removing adenoids and tonsils, we are now in a process of recommending it to be done before IVIG as almost uniform procedure. Okay? Okay, what am I doing here? All right, so we have gone, I explained you the antibiotics, so let me just quickly run down the treatment. I think on antibiotics I have commented enough. Steroid bursts, I believe, I was specific. Now, other therapies used, cognitive behavioral therapy, SSRIs, atypical antipsychotics. Cognitive behavioral therapy is very effective, but only in the recovery phase. When the child is in acute phase, essentially it doesn't work. Here is where most of the controversy abounds, is what do you do with the SSRIs? Now, I have had some problems with it because it appears to be that the PANDAS population has a disproportionately high adverse effects or side effects of SSRIs. Okay? A lot of these kids, instead of getting better, actually get worse. The second problem, and that was purely ethical problem, was that we are the only country, Western country, or what they call it, civilized country, whatever that means, that actually allows prescribing the SSRI to children 12 or below. You cannot prescribe SSRI in England or Norway or Sweden. And the reason was summarized about 4 years ago in the editorial English Medical Journal, where it simply said, there is absolutely no studies presented until that time to show any benefits in children below 12, and there are plenty of evidence that there are significant side effects. Therefore, you should not prescribe it. Now, we can live here. So, they have been tried, and actually, if you look at the NIH site, they recommend it. So I don't have a problem trying it. However, it almost never solves the problem. And as I said, if you do have a side effect, well, obviously you have to stop it. Now, IVIG treatment is kind of fascinating because it's a very simple procedure and has been used now for decades. As you know, the first treatment was actually for Guillain-Barré. And I think this is important to realize, is that the books tell you the dose is 2 grams per kilogram. So when I was designing the IVIG treatment for PANDAS in 1999 and 2000, I went back into literature to figure out where did they come up with this 2 grams per kilogram. It just didn't make any sense. And what I found, it's actually somebody woke up at Boston Children's, woke up in the morning, wanted to be first, in the literature, and came up with it. Now, if you look at historically, the first immunomodulating treatment ever used was the exchange transfusion in babies with autoimmune jaundice, rhesus factor jaundice. Okay? Now, the well-proven formula was 2 volumes for 1 volume. That means 2 mLs of blood given for 1 volume of the blood contained in the body. When you do that calculation and try to give a 2-to-1 volume in immunoglobulin, then you find out actually the perfect number is 1.49 grams per kilogram. That means 1.5 grams. So I have been using 1.5 since, let's say, 2000. Interesting enough, we found that it works actually quite well. So it's in a way cheaper than the 2 grams, but it's more effective. So that's, good news. The bad news is that, you have people who have been trying to use 1 gram per kilogram, 750 milligrams per kilogram, and give it monthly. It was like imitating, immunodeficiency treatment. And I got to warn you about that. Actually, those kids frequently get worse because of accumulation of the circulating immune complexes. So at this moment, the standard is 1 treatment, 1.5 to 2 grams, depends which reference you want to use, and that's that. Finally, and I think my colleague Beth Latimer is much better at this, plasmapheresis. Plasmapheresis actually was used, and I used it in early 2000, and actually it works quite well as the IVIG. But we found 2 problems with it. Number 1 is it has much higher side effects. And number 2, we documented higher incidence of recurrences. So as of this moment, we kind of reserve that for specific refractory cases. All right. Now, here is something that nobody wants to talk about, and let me talk about it. There are 2 stresses that the parents with PANDAS experience. First is a psychological stress. As a rule, mother has a gut feeling there is something wrong with the child, okay, but she cannot put a finger on it. So she tells to the father looks at the kid and says, oh, he's just spoiled, okay? Until father has a chance to see that kid for longer period of time, long weekend, vacation, whatever. Then father gets concerned. Father tells it to the rest of the family, and everybody is looking at them. He's fine, look at him, okay? Why? Because these kids, unless they are completely decompensated, if they are exposed to the other people, visiting somebody or whatever, they're going to hold it well together. But the moment they get out, they get into your car, they just go berserk. I did just for a kick, okay, ask Wendy to send me, and I had some information. And here is fascinating part. Before the IVIG treatment, I calculated, and I had about, I think I reviewed about 10, 15 cases. Per year, with valid insurance, outlays were somewhere between $3,000 and $9,000, roughly. Insurance covered expenses per year were probably $18,000 to $55,000. How did I get to this? A lot of these kids have 1 or 2 hospitalizations at a psych ward. You're talking 3 weeks, you're talking $27,000, $28,000 pop, okay? Now, average cost of IVIG, if you do it in outpatient department, with all the fees, obviously it's dependent on the weight, it's probably somewhere between $6,500 and $21,000. After the IVIG, and again, I took about 10, 15 cases, cost per patient per year, and I'm talking outlays, okay, basically are limited to deductibles. Obviously, there is a gas, frustration, etc. On the other hand, insurance covered expenses, I calculate that they are probably less than $3,200 a year. So my question is this. You gotta here, take it, $20,000 to $60,000 a year indefinitely. These kids, go for years. You got a procedure that costs you $65,000 to $20,000, and you end up basically with, in 79% of the cases, depend on the source you use, with the normal kit. So I really have a hard time figuring out why insurances are not covering it. You know what I mean? It's a clear money. If you have that, to any accountant, they will go nuts. So I think, this is important to realize, that diagnosis PANDAS early, number one, saves the kid and the family a lot of trouble. Number two, it saves money. Okay? And number three, provides everybody with normal life. Can I give you, am I done here? Oh, I got 2 minutes. Okay, all right. So let me give you 2 examples just to blow your mind, okay? A few years ago, I'm in my office in Hinsdale, and my secretary says, there is a gentleman with his mom wants to see you. Never heard, I didn't know who it was. So I came out. There is a 36-year-old man holding his mother by hand and waiting for me. Story, he has had the PANDAS symptoms since age of about 8 or 9. They couldn't really remember. Compensated. He has had the minor symptoms. But he finished school, got married, 2 children. Lives in the house 2 suburbs from his mother, gets the massive strep infection, GAS. Overnight, goes berserk, leaves wife, children, goes back to mother's house and insists to sleep with her in bed. Obviously, he's 36-year-old. I'm pediatrician. I could give him an opinion. I couldn't help him, and he's now institutionalized. Story number 2. I don't want to bore you with that one. I have, one of my concerns has been, what happens with all these kids who had PANDAS, but were compensated well, functioned, and they grew up? What happened to them? Well, the good news is actually not very good. Most of them remain symptomatic. And at a certain point, with the proper infectious inducement, they can develop severe psychosis. So I think importance of diagnosing them and treating them early cannot be overemphasized. And again, I'm not Dr. Svido, okay?